Welcome to Middle Fingers Up. I am your host, Kieran, and I first met today's guest, Rama, at a South Asian event where we both were on a panel speaking about women's issues, about immigration, survival, lots of health talk, lots of cultural talk, and all of us sitting together having that energy in the room where there was a lot of weight shared, a lot of experience shared. What stood out to me, though, in all of this was Rama, who was sitting few seats, not even next to me, but there's few people in between. I could feel her energy. And not only was she doing a magnificent job sharing her clinical knowledge and experience, but I think what really connected her to a lot of the women in the room, including myself, was that she also makes us deeply personal, the work that she's doing because of her own experience, in which we're going to get into because you're probably wondering, what is it that she does? So Rama immigrated from India with a background in physiotherapy. And like many South Asian women, she didn't grow up having open conversations about periods and hormones and pelvic health and sexual health. Just like most of us, a lot of what was taught or not taught was to push through, normalize pain, and not to ask a whole lot of questions. So you kind of start to fill it in. And when we were growing up, we didn't have TikTok, we didn't have the internet in the same way that many people today can fill those gaps with. So it wasn't until her own experience with pregnancy, birth, and postpartum recovery that the gaps became more apparent. And I think when I was listening to her, really what she talked about was these gaps became impossible to ignore. So the gaps in education, the gaps in medical care, the gaps in between what women are told, quote unquote, is normal, and in comparison to what we actually live with when it comes to our bodies and our health. So the experience led Rama to become a pelvic floor practitioner, focusing not just on the physical rehab, but also on reducing the stigma around women's bodies, around women's pain, and women's health as a whole. So today's episode is about the things many of us weren't really taught when it comes to our health, particularly how everything in our bodies and our mind is connected head to toe. So we talk about why symptoms like poor sleep, mood changes, chronic stress, reoccurring infections, all these sorts of things as women we go through that are normalized, or the pain that we experience, they're not all random. These are all parts of our body and mind that are communicating to us that something's up and we should address it or do something about it. So this conversation, I just want to point out, it's not about fear. And I think sometimes particularly in the South Asian community, we have these taboos around health and death that should we talk about it, we're going to manifest it and bring it upon us. But because this is a conversation about literacy, it's really not about the fact that we have to be afraid and we're going to manifest some health issues. It's actually the opposite. It's about preventative care. It's about building knowledge and really feeling like we can be empowered in our journey, in this whole health journey that we go through. So a lot of today's conversation is building self-trust. So listening to our bodies before they are forced to scream. So as always, we're going to open up with my favorite question. I cannot wait to ask, but maybe before we do that, let's welcome our guest. So Rama, thank you so much for being here. How are you today?
I'm glad I get to do this. Thank you so much. It's such a privilege, Karen. Thank you for giving me the platform, giving me the voice that I can actually share all of my thoughts and spread the word.
I love it. I love it. I'm so excited. Okay, so let's start at the beginning. So let's go into a time machine and go back to pick an age before motherhood, before physiotherapy, before immigration, before all that. Go back and visit little Rama, pick an age. And I want to know what age you pick. And I want to know when you pick that age, what would you want little you to know about her body that maybe no one ever told her then?
I'm gonna pick 13.
Ooh,
Um,
okay. Lucky number 13.
lucky number 13. And the reason why I picked 13 was that was also the age I got my first period in.
Ah,
And I'm going to tie that. There is a very interesting story that I share with my patients. I've shared with my friends about my first period and what happened. But to answer your question, what I would like the 13-year-old me to know is that she's going to be okay and she's going to find out some answers, maybe just by herself, because there's not a whole lot of answers around her. But one way or the other, we're going to figure out a way to find your voice and find some answers.
oh, I like that. I like that. That's awesome. And what is the period story? I'm so
Yes.
curious.
So yes, I was 13 years old, and my mom is a teacher. So back in India, she taught and she used to evaluate papers, question papers, and this was before the age of AI, before the age of automation, computers, and all of that. So she had to go into her school setup and she was evaluating question papers, and they had to be there from morning till night. You start in the morning, and then all day is when all of these teachers huddle in together. So this was during exam time where she had these assignments where she would be 3 days in, 4 days in, where from day to night she was just stuck at school. And me and my grandma were home, and I knew that this was a routine. This was the usual exam period routine. So one morning, random morning, I come back in the afternoon back from school, and I notice that I got my period. At the time, a few of my friends had their period, so I kind of sort of had an idea of, oh, maybe this is my period. This is what we expect. But what freaked me out was I had no preparation. I didn't have a pad. I didn't have any information on what do I do when I get my period, because nobody had ever talked to me about it. And grandma was the only person I had as my resource person there. So this was day one. And I thought, you know what, let's just wing it. Let's keep changing our underwear because it was still spotting at the time. It wasn't like a proper period. So I just thought, yeah, I can wing this. By day two, I had ran through all 12 of my underwear. And I had, I would secretly go and scrub them, wash them at the sink and dry them, because there is no dryers in India. It's so hot and humid that you just have to dry it on a clothesline. So my grandma catches me scrubbing and washing my clothes, and that's odd, that's not, I'm not on top of my laundry where I would do that. And she goes, "What's happening? Why are you washing your clothes? Like, why are you washing that often?" So then I had to confess, and I said, "I don't know. There's something going on. I think I got my period. I'm not sure what to do." And again, this freaked out grandma because she is a whole generation behind my mom. So she goes flabbergasted, completely speechless. And she tried her best to assist. So she tried to find resources, and she tried to find from my mom's cupboard, okay, maybe this is something you should use, or maybe this is a pad you should use. And just, she didn't know how to use one. She'd never used a pad. She'd never seen one in her life, but she knew that there was something in mom's cupboard. So she goes and pulls out a package from mom's cupboard, hides it, covers it up in paper, hides
Right.
it, and gives it to me and says, "Okay, figure it out, go use this." So this is why I brought back the answer and said 13-year-old me did not know anything about what a period would be. What should I do when I get my period? What is the right way to use a pad? How do you stick it? Where does it go? Do I stick it on my body? Do I stick
Yeah.
it on underwear? Where am I sticking this thing?
Yeah.
So that was a kind of a torturous 2-day event until mom comes back home, and I go, "Mom, what do I do with this? Tell me, what is the answer?" And then, of course, my mom explained everything. So yeah, things are fine. I survived.
Yeah. Yeah, what a story, right? And I feel like so many so many women like you and I are listening right now, reliving their own childhood experience of when they got their period too. There's always an interesting story that I think has like a lot of messages and
Yes.
a lot of things communicated without communicating, and lots of ways that we're internalizing what this new beginning, this journey of having our period is going to be. So I'm curious, like for you, what do you believe was quote unquote normal that you know now really wasn't?
Yeah. Yeah. So I think the biggest myth busting that I realized as I started to grow older, as I started to just evolve and learn new things, what I realized I had normalized was anything and everything related to my intimate health. And I use
Mm-hmm.
the word intimate because it doesn't necessarily mean just periods or just a specific part, reproduction or pregnancy or whatever. Anything in this bottom area, anything below the belt, if you can call it, it was just something to not talk about, something to not ask questions about. And until it got to a point where it was so bad that you couldn't ignore it, you don't bring it up.
Right.
That was the culture. That was how it was normalized. And this was despite being from a very educated family. This was despite being culturally progressive, which I absolutely am grateful for my mom and dad and my immediate family. But my extended family probably might not have been as culturally astute or as forward thinking progressive. So that was definitely something which was normalized, where we said, until it gets to be a problem, don't talk about it.
Yeah, yeah. And I think it's interesting. So many of us grew up in so many different contexts, whether it was in a culturally progressive home, highly educated, not poor, rich, whatever in between. I think somehow all of that matters not the more I look
Yes.
back, because I think the society had decided what kind of education you were going to get, whether you were living in the Western world or living in India. Of course, some differences because of resources and things we have access to, but the messages were literally the same. Like
Yes.
here, there would be, first of all, very rarely would you see like a pad commercial, and many of us grew up only being allowed to wear pads. And so you'd see tampon commercials and all these things where it's like you can do everything, right? And so then you think, "Oh, okay, so my pain tolerance must be so low because I'm in so much pain." And so all these different messages that we kept receiving, I think, were bottom line, just normalize it, suck it up, or as you said, when it gets really bad, then obviously you go to the hospital, but apart from that, you're fine. And so if we were going to flip that, though, flip the switch, like what in the work you do today, like what do we hope is the message that parents, mothers and fathers, and maybe even fathers more so than mothers. But what do you think is a message that you hope we're giving our children? I only have boys. I don't have a daughter. So I have a responsibility to teach them too, even though I'm not teaching them how to wear a pad. But there's lots of context I have to also responsibly provide. So what do you hope is the way that we are teaching our kids today?
I think the biggest advantage that we have in this day and age is access to information. We are absolutely spoiled for information
Yeah.
everywhere, sometimes to the extent of bordering into misinformation, where we have to sift through and be careful that we're picking the right pieces of information. But generally, on a broad base, I think we've got great access to information. So that brings us an added responsibility that if we have access to that information, it becomes our onus as parents to impart that piece of knowledge or that piece of information to our next generation, to our kids. And one thing that I would love for parents to see now, or to see parents do now, is if they can practice radical acceptance while teaching kindness and empathy. this would be the number one thing. And you can spin it in many different ways. You can take it in the form of health. You can take it in the context of consent. You can take it in the context of what's appropriate, what isn't appropriate. I use the word radical acceptance because our society, especially South Asian society, is so heavily ridden with norms of what should and shouldn't be done. So if we can just get rid of the should be's or the should haves, and just practice radical acceptance, saying if a child comes to you and says my period's hurt or I feel a certain way, then yes, just accept it, take their word for it, and then move on to the next step on what it should be and where should you seek help or information from. That would be my number one hope and ask, is first find yourself the information and then impart that information with radical acceptance.
Yeah, I like that, because I think if we go into the next little bit of our conversation, some of this is growing up with silence. And the way I look at it is like then and now. And when we talk about growing up with silence or normalizing, or don't really go there and talk about it. And I think a lot of us would say probably the most amount of education we got was about vaginal hygiene. So
Yeah.
cleanliness. And I think there's a lot to be said about that. But I think it's sometimes, maybe it's just me, but it's like easy to think that this is like a cultural or generational thing, or something like our parents didn't know how to handle, which all can be true. But I think to me lately, what's been striking is how much of that silence is still being reinforced today, not just at home, but like through the system. So systemically. So here in Alberta, where we are, health and sexual health education has been changed by our government. And so now it's an opt-in. So before, we just always, sometimes parents didn't even realize it till their kid came home and told them all this information. Oh, that it was the week or the time to, be in gym class and learn about health. Yes. And now the government has made it that you as a parent have to sign a form giving permission. And I think there's still a lot of fear around what teaching kids about their bodies will encourage or expose them to, versus, or even like take away in terms of like their innocence. And I think it makes me wonder about, are we actually like that far from how we grew up, or like, are we moving forward to move backwards in some ways? So I'm curious for you, like, growing up, what did silence around bodies, teach us? Or maybe even you have clients that come in and that you're seeing some patterns with them when it comes to health, sexual health, pain, and endurance. Maybe you can speak to that a little bit.
Absolutely. Absolutely. And that's such an important topic that you touched on. Just this year, my daughter's in grade 6, so I did sign the form.
Yeah.
Saying, yes, we do need to talk about this in school, and kids do need to learn that. But what I commonly see in my clinic or in my practice is when someone comes in, the lack of that discussion, the lack of that information has huge ramifications. For a very rare example, this is not a common occurrence, but this just shows you the gravity of how huge of an impact this could have on someone's life, on someone's identity. So I had a young woman come in, and she was the age of 15, and she came in. She was referred from her gynecologist for a pelvic health exam. And one of the reasons that she came in for was there was pain around her pelvis. So it's a very common complaint. It's a very usual complaint that people come in with. But what struck me was it was kind of vague. A 15-year-old coming in with pain and not giving much information was sort of vague, which led me to dig a little bit deeper and say, what kind of pain is it? Where do you have the pain? And, all such questions. So at the end of it, without giving out too many details about privacy, the bottom line was this individual had never had her period, and she was age 15. She did not know what a period would be, which is rare in this day and age. I think that is rare that a 15-year-old doesn't know what a period is. But as I dug deeper, it wasn't that she didn't know the process of how a period goes. She just didn't know in her body, where is the blood going to come from? And then clinically, when we were examining, we realized that this child doesn't have an open vaginal opening wide enough that the blood can actually come. So this is a genetic condition where the part of the vulva isn't fully developed. So she only had her pee hole and she had her poop hole, but the vaginal opening wasn't really a vagina. And so ends up being that this individual did not have a uterus, and therefore she probably would never have her period because anatomically the part that gives her the period was missing. But also the fact that we had to sit down with a mirror and explain, this is your pee hole, this is your period hole, this is where it would have been, and this is where poop comes from. Because up until age 15, unfortunately, she's never had that experience. And then that brings me back to all of the doctor's appointments, all of the physical exams that she's been in. What kind of conversations were they? And if this was a condition, how did the parents navigate that? All of these were questions that came to mind. And that was the day when I made a mental note. And this was a number of years ago. My daughter was still, I think, 3.5, 4 years old at the time. So I made a mental note because I have a daughter. I said, okay, from the time she's old enough to understand words and body parts, I'm going to start naming body parts. I'm going to start bringing this into conversation. So it's not a one-day event where we get our kids to sit down and say, okay, we're going to talk about periods. We're going to talk about birds and bees and reproduction and stuff like that. It's an ongoing conversation. It is as common as saying you've got this hairstyle, and if you're going to change up your hairstyle, okay, what does this hair look like? What does that hair look like? Or if you're changing up your clothes, what would seasonal appropriate clothes look like? It's a very nonchalant conversation. That's how it should be, because these types of nonchalant conversations would give the kids the confidence that, oh, if something feels odd or if it feels different, I can go back to my caregiver. I can go back to my safe space and ask them, why doesn't this feel like everything that my friends say would feel normal?
So well said. And I absolutely love that you brought up this education starts as young as possible. And even if we are having kids, like as the caregivers preparing while we're pregnant and then post-birth, like how are we having these conversations? How do we normalize what's actually meant to be normalized, such as diaper change? And we're still having conversations today about the bar so low sometimes for men, and we're like, oh, this is so great, the father changes his daughter's diaper. And it's like, we got to raise the bar a little bit higher than that, because these are babies. And if we're having men and women and non-binary and everyone in between changing a little penis diaper, then why are we congratulating someone for changing a little vagina diaper? And
Right?
in some of our cultures and language, we don't even have a name for a vagina. It's
Yes.
considered to be something so dirty and terrible, yet it's at the same time you get to this age and now it's sacred because this is where babies come from. So it's all this stuff in between, like you said. And you're right, it's not overnight, but it does start with us as the adults getting comfortable and not giving weird names like wees and peewees, like
Yes.
giving full on real names, because we're building to the developmental stage that they're in. And, like sexual health and health in school isn't the only place that they should get that education. But I think for a lot of us, it's where it sometimes starts. I think sometimes parents may not understand the ages and stages of where their child is at. And when they come home from school and they're like, oh, you're doing grade 4 math division. Okay, you're ready for that now. It goes the same with sexual health. And so sometimes when they come home saying, hey, I learned about consent, and it's like, oh, right. Okay. And I think we could be working together with the educational system, but everything is so divided. And so I think it's saddening, because we are teaching kids again to not understand what safety is for their body. And even this young person that you talked about, I mean, I think, how disheartening would it be for a 15-year-old who has so much awareness, who's closer to adulthood than childhood, and to imagine like the lack of confidence and the insecurity and all that of not knowing what's happening. And then as you're learning at 15, now that's like also a grieving process she has to go through as well. So
Certainly. Yeah.
it's a lot. It's a lot of stuff that we avoid. And so I'm curious for you, like, what do you think as adults, like, what are people actually afraid will happen if children understand their bodies?
I think the biggest part of that hesitation comes from the purity culture, the culture of purity, where a lot of South Asian families do believe that you have to withhold yourself back and not indulge in intercourse before you are in a committed marriage. And a lot of that, I think the purity culture decides what is good and what is bad. That's the lens that people are looking at it from. And if they give the kids access to that information, I believe the understanding is they give them permission. I think they're confusing access to information as permission. It's probably as silly as saying, if you teach your child about drugs and how what are the harmful effects of drugs on your body, it almost, if you run the parallel, it's like saying, just because you tell your kid or teach your kid the effects of what drug abuse could do on your body, you're giving them permission that yes, you can go ahead and try drugs. It doesn't work that way.
Yeah. Yeah.
In fact,
Yeah.
it does the opposite. The more you talk about it, the more you reason it out, the better informed they are, the more confidence you're building in the children. Because
Yeah.
these young individuals, they are looking at us for some sort of regulation. Their frontal lobes, their brains aren't evolved enough to understand the difference between inhibition and control and regulation. So if they're looking at us with that lens of, okay, guide me, which direction should I go from, should I go to? And if we withhold that information, if we're gatekeeping that information, it only drives more curiosity. And when kids are driven by curiosity, they access information in any which way possible. And sometimes that might not be the right avenues to access that
Yeah.
information, which leads to more harm than good.
Totally.
Pornography is not the place where you learn about sexual health. That's not the place where you see body parts or you learn about body image. Yet, so many of our individuals who are in this young generation bracket, that is their access to information because nobody in their adult circle has had the confidence to have these discussions with them.
It's like sometimes as caregivers, you think you're protecting, but really, I encourage that, is it protection or is it how you're addressing your own discomfort and how maybe you were taught by generations before, or your own beliefs? Sometimes religion comes
Yeah,
in hand here and it becomes the thing that gets in the way about learning about body and sexuality and autonomy. And I think it's really important to push that a bit and challenge it, because at the end of the day, it's about having less sexual violence.
yes,
It's about having more safety in the room when you have young genders. And it's not just a sex consent. It's all these sorts of things, like I remember when my boys were little, just like little kids do, they push the boundary. And if you remember, maybe when your daughter was little, it's like, please, can I have this? Please, please,
yes,
please, please. And then sometimes, depending on how tired of a parent you are, you might give in and you might say, fine. And I think that is such a simple example of, if we do that over and over between a child and a parent, we are teaching them that you can push the envelope and you can keep prying and prying. And think you might want to protect your kids from the sex stuff, but that is also where they're learning, like everyday
yes,
interactions. That right there is like, oh, I don't need consent. I just got to keep, pushing,
yeah,
pushing and pushing, and someone will agree to buy me that thing or give me that thing or
yeah,
send me a nude or wherever you want to take it. So I think sometimes we think, if by eliminating some of that body talk, we're okay, but it's showing up in everyday innocent conversation. And so we might
yes.
as well do the full rounded teaching, as you're saying, or have people around you that maybe you feel more comfortable, like your younger sister or your younger sibling, or a
Sure.
relative that
Yeah.
you're like, hey, I feel really comfortable with you talking to my kid about this because I'm not there. But whatever it is, at the end of the day, we have to push for it because it shows up for us, as we're in our 40s, and So sometimes I think even we get embarrassed to go to the doctor to be able to say, hey, I'm having this interesting vaginal discharge,
Yeah.
and many of us have been taught that that means you're dirty and
Right.
just you're not washing good enough. And so I think when your pH balance is off, there's again your body's communicating something. And so all these sorts of things are connected, and I think as the adults, it's our job to sort of be curious, as you said, that radical acceptance of this is occurring, whether
Yes.
I agree with it or not, it's happening. So how can I best prepare myself to address it? Anything you want to add
Certainly.
about that before we move to the next piece here?
No, I love the fact where you brought on another trusted adult in the conversation,
Mm,
because there's actually science behind it. What you're tapping on is actually really evolutionary science. So as people evolve, as young kids, when their brains are going through development and they are getting into the teenage years, evolution has designed our brains in a way that we will not be listening to our parents, and that's legit, that's granted. That is what evolution has designed us to do, because back in the caveman days, young people needed to go away from the herd, they needed to go away from the group so they can form their own little tribe or own little group, and they can hunt and gather, and they can propagate. So this is how our brains are evolutionarily designed. So in that scenario, having teenagers be rebellious or revolting and not having that emotional connect to some extent is accepted and is almost anticipated for parents. In that situation, it is our job, long before the kid gets into your teenage years, right when they are maybe 5, 6, 7, or in their preteens, to have a parallel mom stand by, an aunt or a trusted friend who can stand by and come in, whose values you trust, who can give the same advice or similar advice, and they hear it better because it's not coming from mom. It's not
mm-hmm.
coming from dad. So having these standby figures, which are not your primary mom and dad or parent caregivers, and having them be a standby mom or dad is so crucial. In fact, it's almost beneficial, because you could say one thing and you could say that 20 times and they won't hear it. But then the aunt says it once and they're like, okay, sweet, we'll do it.
Yeah. Yeah. Masi said, or,
Yes.
mama said, and you're like,
Right?
oh, great. But isn't it so funny, because if we take out the colonization part of how we were, purity and all that stuff that was like put in us, and go back to our ancestry, that's how everybody was. It was a village,
Yes.
literally. I mean, Western world uses that as a
Yes.
quote every day. It takes a village, and we're a collective as a community. And,
Yes.
it takes the burden off as well. You think of the teamwork mentality at work. Everybody is doing their part
Yeah.
to deliver outcomes, and it's your child's health is the outcome. So
Yes.
I agree with you. I think that's lovely if we have people in our circle that we truly trust. Now I think sometimes it's hard because many of us have experiences or know people who've had experiences where they have been sexually assaulted by
Yes.
family members. And so I think these experiences then make people kind of turn the other way and say, I have to protect my kid. And I think there's a huge, yes, absolutely, that's our responsibility. But also we have to teach that safety in our children as well. Of some of us weren't taught how to trust our gut
Yeah.
and know where safety is, and know, okay, like we always joke, we would have to walk to in a room and hug the 30 family members out of
Yes.
respect. And not all of those family members were safe people.
Yeah.
And we knew, but we didn't want to get in trouble for it. And so I think these are the things that we can take and sort of edit out and say, okay, that means then I have to like help my kid understand how to trust their gut,
Yes.
and build their own self-confidence around, these are safe people, these are not safe people, or at least communicating, I didn't feel safe. But at the end of the day, it's building that community around their growth and their adolescence. So that's well said.
For
I like
sure.
that.
For sure.
So, we talked a little bit about periods and hormones. I just want to kind of go back there a little bit, because I
Yeah.
think you probably see this a lot, but this normalization of pain.
Yes.
And the thing that always come to my mind is if you ever put a new group of women that just met in a room together, 9 to 10 times they're going to leave knowing each other's birth stories if they've had babies. And it's like this bonding experience that women go through. But what I noticed happens is like, you get a lot of credit with the amount of pain you endured. And then those that maybe didn't have a 60-hour labor feel like, oh, well,
You
my
had it
pain,
easy.
yeah, it totally, right? And people
Yeah.
will say that to you. People who don't have kids will say that to you. It's a weird thing.
Yeah.
And I think as women, then post birth, and I remember this with me, you go to the doctor and I'm like, well, I birthed 2 kids naturally, no meds. So I think I'm just being a baby. And I remember one doctor being like, please don't ever compare your pain. Like delivering a
Right?
baby, you're gaining something in the end. And most times you have the capacity to some degree get through that, whether it's with meds or not. This is your kidney stones, like 2 very different things.
Yeah.
So please be honest when you tell me on a scale of 1 to 10 where the pain's at. And I always think about that because I think we go through these painful experiences in life and then we think we have to compare our tolerance levels. Oh, I'm a wuss, I can't handle it or whatnot. So that's where we kind of silence some of that. And I think it shows up in the hormone period, just endure, just do it. It's the cramps, you got to go to work, pain meds, birth control, all these kinds of things. So I just want to talk to you a little bit about like, how do you know, and maybe how do you educate women when something is discomfort versus a red flag? So like sometimes we don't recognize it and it is at a red flag status because we're like, oh, just deal with it, just deal with it. And again, like we said at the beginning, we're trying to do preventative care. We're trying to take care of ourselves without having the most amount of medical resources. If I can address this pain in the quickest, best kind of way versus having gone through all this pain and now I have to get surgery or whatever it is. So just curious, like, how do you educate and talk to your clients about discomfort and pain and where in that do you normalize it?
Absolutely. I
I said a
love the
lot.
fact that you brought this up because there's so much to explore here. But I'm going to start off with a little bit of a nerdy statistic. And this just paints the picture
Okay.
of how grave the situation is and what is the extent of how much we've normalized. As women, how much have we just tolerated silent? So, overall, globally, up until a few years ago, the field of women's health wasn't much talked about, wasn't much researched. And we know that recently there have been a few handful of studies that have done the right amount of work, which shows what is the expanse of how many people in the world actually say yes to being affected by anything in their pelvic floor. This could be bladder leakage, this could be incontinence, it could be bladder urgency, a burning with peeing, it could be inability to pee, where they just don't feel like they are ever fully emptying their bladder. It could be period related, painful period, excruciatingly painful period, PCOS, endometriosis. It could be pain with intercourse, having even the slightest bit of discomfort with intercourse to excruciating pain where someone bleeds after every time they have sex. So it's a whole range, it's a whole variety of things that women have endured, and the silence around it is appalling. So if we take global statistics, when a list of these symptoms were given to individuals, 60% of women said that, yep, we have this. And this is just 60% of those who agreed to be brave enough and courageous enough that they would actually report it. This is not truly 60% of the global population. 60% of those people who actually found the voice, found the courage to say, yes, I am affected by this situation. Uh, Out of those 60%, they asked how many actually went to their doctor and how many actually sought help. And it was only 17, 17% spoke to their primary care physician about it. So that it itself tells us the huge gap of how much of a mismatch there is. There's this huge population that says, yes, I do have these symptoms, but I'm not going to talk to my doctor about it because, oh, it's not that bad. It's not bad enough, or it's not severe enough. So I start with this number, I start with this statistic, because another tagline when it comes to pelvic health dysfunction is 1 out of 4 women is going to be affected by it. So if it's a room full of women, every fourth person that you meet will have some sort of pelvic floor dysfunction at some point in their lives. And this doesn't mean they have a disease. This doesn't mean that they have something wrong with their bodies. They are going to be affected by these symptoms to some extent. Yet, it's not 25% of the global population that's seeking care. We'd be far more busy if that was the problem. That's not what the situation is. So now that we understand how much of an impact there is, it shines a light on how many of these symptoms are underreported, how many of these symptoms are normalized. Because rather than doctors dismissing it, doctors normalizing it, which is again an issue in itself, we can talk about that at a later time. But rather than anyone else dismissing it, a lot of these women are underreporting it because they're self-dismissing. Nobody else says that you don't have a problem. It's the person themselves, it's the individual themselves saying that, oh, I'll talk to the doctor when it's that bad or when it's this bad. So whenever I give them an analysis, I say, don't wait for discomfort. By the time you feel discomfort, it's bad enough. You don't have to wait for pain to show up. So it's not a scale of whether it's just discomfort or whether it's a red flag, 10 out of 10, 20 out of 10 pain. The moment it dwells into discomfort where something feels off, that's it. That's your cue to reach out. That's your cue to voice it and say, I have this symptom. I don't know why it's happening. How serious is it? And start the conversation right then before it becomes into something which is a red flag that needs extreme attention.
Ooh, I'm so glad you brought up the stats, because I feel as a community, like in particular the South Asian community, we don't have all these stats out there. And it's exactly what you said, because they're underreported. People are living in the stigma and all these other things in between. And I think every time we talk about this, we're building that data to be able to help not only our generations, but the generations that come after us. And so I love that you go there and you talk about the data, because it tells a story. And the story is we have to talk more about this. And if you're like 1 in 4 women, right? Then, I mean, there's 4 of us in this house, and I have pelvic floor issues. Right? So even though I'm the only woman in the house, but there you go. So I think so many of us are walking alongside each other with like such similar problems, yet we don't feel comfortable to be able to say, yeah, this is, what my pelvic floor therapist mentioned to me. And even when I met you and you were having this conversation, one of the other things that really I connected with was my own story of, I didn't know anything about pelvic floor. Right. And earlier we're talking about being highly educated, all these things. It matters not, because in my whole pregnancy, it wasn't discussed. And if it was, I missed it because I was probably overwhelmed, but I do not ever recall it. And it wasn't until my first was a year old, and my friend who does post and prenatal care, she's like, hey, if I say anything, this is the thing I'm going to say, go and take care of your pelvic floor. And I was like, what is that? Yeah. I didn't even know. And then I didn't do anything, and I had my second son. And then about 6-7 years ago, and up until recently, it started to get worse and worse. And I didn't understand how my pelvic floor is connected to other parts of me and how stress levels can impact that, because just like in society, everything's divided. We do the same thing with our own health and mental health. We live in isolation. If I'm feeling low, I'm not connecting it to a part of my body. Yes. If part of my stomach's not doing well, I'm not connecting it to my stress. And so you made a really, really good point when we were doing the consult, which was, you wanted to make sure we took time to talk about this head to toe, like how everything is connected. And so I'm wondering if we can spend some time on that and what you'd like to share with us.
For sure. Absolutely. In fact, it goes I would say it kind of goes based on timelines and then head to toe, because even in the same individual, it's connected. Our entire body is connected. Our nervous system, our circulation, our sleep, digestion, hormonal balance, all of that intricately is connected. And how our muscles behave, how our ligaments behave, they speak to each other. And this is where we have to understand that these are systems that overlap versus work in isolation. It's like a well-oiled machine where all of these little circuits, they click into each other. And if one thing starts to not function as efficiently, then it's going to have an effect on other systems in the body. Just as an example, let's just say for a women in midlife, you and I, we are in our midlife. So in this stage of life, the hormonal roller coaster is quite evident. Our hormonal system is trying to recalibrate, trying to adjust and understand what is our baseline, what is our default, because the early reproductive stage, the hormones that were relevant then probably are not as robust and relevant as they need to be right now. And we're not at that stage where our hormonal reserves have all extinguished. So you're not postmenopausal. You're not at that point where your estrogen has completely depleted. So when we are in this in between roller coaster, a lot of new things start to come up. A lot of weird symptoms show up all of a sudden. Sleep disturbances where you just don't feel like you can fall asleep easily, or even if you do fall asleep easily, you wake up multiple times a night. If you wake up multiple times a night, you're probably thinking, oh, I'm awake, might as well go to the bathroom. So you end up going to the bathroom to pee, and that sets up a cycle, that sets up a habitual cycle. Now your bladder is retrained and it's used to waking up at 2 a.m., 3 a.m., going to the bathroom. And every night, 2 a.m., you go to the bathroom. Every morning at 5 a.m., you're waking up again, going to the bathroom. So all of a sudden, now the bladder is operating at a lower capacity because it's just trained itself to not stretch as much as it used to. So it translates that into your daytime peeing. And now you're seeing that, oh, why am I peeing so frequently during the day? And how does that cascade down? So now that you're peeing more frequently all throughout your 24-hour time frame, your hormones, your reflexes, they start to recognize that the bladder is emptying more frequently. So now your muscles are thinking, why is the bladder being so robust or so overactive? Am I not clamping enough? Are my muscles not tight enough? So then the muscles jump in and say, okay, we've got it. We're going to go really tight. We're going to clench super tight to try and prevent this situation. But then that makes the bladder ring a louder alarm. So every time you get close to a bathroom, every time you get the urge, you're like, oh my gosh, I have to pee. Otherwise, I'm going to leak. I'm going to pee my pants. And then the muscles try and hold harder. Sometimes it's successful. Sometimes it's not, depending on where we are. And then you start to drink less water because you think, if I drink less water, there's not enough pee that's going to be made. So let me do this. But because the water is less, your urine is more acidic. So now your pH has changed. It's more acidic in nature, making it go even further. And that disrupts your sleep all over again for a whole different reason. So now we've come a full circle. It was the sleep that started the bladder retraining, which led to certain habits, certain overactive situations. And then because of the overactivity in the bladder, because of the acidity, because of the compensation that we thought we were doing a good job at, we've now retrained our bladder to work even more hardcore than what it needs to. So this is how things come into full circle where things are connected. This was just one example of how a symptom, which is seemingly innocent, not having good sleep or maybe interrupted sleep, how can that affect the bladder and vice versa? This is just one way. But then when I was talking about timelines or lifespan, this is where I speak and talk individuals through all of their life stages, all the way from puberty to menopause and beyond, because at every age and stage, your body is going to react differently. Your systems are going to interact differently, which then results in differences in how these symptoms reproduce. So your period symptoms when you were in your puberty reproductive years, they're going to feel different. When you're in perimenopause, when you're fluctuating, that's going to feel different. And then post menopause, it's going to feel different. So just understanding the whole scope of what age and stage you're at and how these body systems interact with each other is just so much more important.
Oh man, like I'm listening to this and I'm like, do you have cameras up in my house? Like, but then that's also telling that, like what I'm experiencing isn't always going to be unique. It's
Yeah.
going to be very, like you said, in the stage that I am, which again, so many other women
Yes.
are experiencing so many similarities, which then there is something to do about this.
Yeah.
There is a place to go and talk about this and gain some relief. And I think we don't have to do this in isolation. And I think the way you describe that, I know, like, all the women listening today are going to be going through exactly what I was in my head. Like, holy crap. And we didn't even talk about why are we not sleeping? Because
Yeah.
that could be a mental health thing. That could
Yeah.
be a stress thing. And so the body and the mind are so connected. And here we are trying to maybe isolate and deal with one thing, but there's all these other things going on. So I mean, tell me more. This is just, I could just like literally for once in my life not talk. I don't think I need to.
No, this is fabulous because, and I think even if we take a symptom, for example, so let's just take bladder leakage as a symptom because that's the most common one that people report when we ask them about pelvic disorders. The bladder leakage is the number one thing that comes to mind. That is the most reported amongst all of them. So even if we take that one symptom at different ages and stages, it means something else. For example, bladder leakage in a child who is beyond the age of potty training. So somebody who's supposedly expected to have good bladder control. So let's say ages 5 and up, right? Between 5 and 11, if a child has bladder leakage or bedwetting, and this is independent of their gender, it could be male, female, any gender. It doesn't really, gender has no bearing on bladder control. So when that population has lack of control or some sort of a dysfunction in control, it could be because they're constipated. It could be because they don't have the ability to recognize where these muscles are and how to function. It could be because they are really anxious. As children, they are very anxious, and it's the anxiety that's making them clench their muscles so hard that they just haven't learned how to relax the muscle to allow the pee to flow. It could be as simple as fear of missing out. Kindergarten kids are so busy playing that they don't want to take the time to actually take 2 minutes and go to the bathroom and pee, because what if their friend plays and they miss out on that playtime, right? So it's a whole host of different things. And that's in that population. When you go a little bit higher, if you are in taking somebody who's in their mid 20s, for example, and they have bladder leakage, now we begin to wonder, is it because this person has a change in their hormonal balance? Is it because their pH in the vaginal wall around the vulva has the pH changed, causing their muscles to not function effectively? Or are they more prone to having UTIs? Because urinary tract infections are very, very common amongst young individuals in their 20s, because this is also the time when most individuals become sexually active. So there's a lot of exchange of microbacteria, which leads to UTIs. UTIs lead to frequent urination, and sometimes that frequent urination causes burning and causes the muscles to not function effectively. So bladder leakage in this population means something completely different. Bladder leakage in a postpartum individual could be because of birth related injuries. Did they have forceps during their delivery, or did their muscles get overstretched during labor? And therefore, postpartum, they have lack of control. They just aren't back to the muscle tone that they had pre-pregnancy, and therefore they're having a hard time managing their bladder leakage. So that could be in a postpartum individual. If we cut forward to somebody who's in their 40s, early 40s, perimenopause, their hormones are going through a big recalibration. There's a huge roller coaster happening, and that estrogen dip whenever it happens, has a significant role to play in our sphincter muscle control. So because of that dip in estrogen, some months it might feel like you don't have very good bladder control. Other months it might feel like, oh, I'm totally fine. I'm not leaking at all. And I've got great bladder control. And then if you go ahead into our menopausal population, that end of the population always has lower levels of estrogen than all of the other time spans that we've spoken about. So then we're navigating with effects of what does that vaginal muscle weakness feel like? What does the urethral muscle weakness feel like? So bladder leakage could be one symptom, but depending on what age and stage we are, what we are presented with, it could be a whole host of different things.
Hmm. So for people maybe today that are like, oh, I didn't realize this. This is something that I'm just becoming attuned to with my body. Like for those that aren't familiar with what is pelvic floor, like what is your role? Can we talk a little bit about that and a little bit more about why would I go see you? How would I know that I need to go see a pelvic floor therapist?
Absolutely, absolutely. So I'll start by elaborating the functions of the pelvic floor, which then gets us to go to the idea of what would happen or why would I need to see a pelvic floor physiotherapist. So the main function of the pelvic floor is to support our pelvic organs. We've got our organs, which is the bladder, the vagina, and the uterus, and our rectum. These are the main organs that the pelvic floor supports. It's like a hammock. Imagine it being like a trampoline or a hammock. And then we have these organs sitting on that base, which is a muscle base. So whenever it's in a happy position, whenever it's efficiently working, the trampoline stretches under the weight and compresses when it doesn't need to. So it has to undergo a good lengthening and compression as the situation demands. That's the hallmark of a healthy pelvic floor. It supports these organs, it compresses and lengthens when it should, when it's asked to. Those would be the main tasks of the pelvic floor. Another task is to act like a sump pump. So all of the blood circulation from our legs, from our extremities, getting the blood back to the heart and refueling it and kind of circulating it back into the rest of our body. It needs a little bit of a sump pump kind of an effect where it pumps it back up to the heart and does that. So if it's not doing an efficient job of pumping it back up, then we run into something called pelvic congestion, or we run into pelvic heaviness and those kinds of scenarios. And sexual and reproductive function is the most obvious one that a lot of people are aware of. And control, sphincter control. So having bladder leakage stopping, or making sure that we only allow bowel movements to happen when we want them to happen and doesn't happen involuntarily. These are sphincter muscles, which are supposed to act like little clasps. So these are the 5 main functions of what the pelvic floor does. And if any of these go off kilter, if you're not feeling right in any of these, for example, if the support system isn't working, that means if you feel heavy in your pelvis, or if there's any pressure in the pelvis where you have a sensation of almost a tampon slipping out or something heavy in between your legs in the vagina, filling up in the vulva, then that is a good reason to go see a pelvic physiotherapist. If there is any sense of lack of control, that could be a sense of urgency with the bladder or bowel movement, not just bladder. Bladder is the common one that we talk about, but people do encounter the same situation with their bowels as well. So having difficulty with bowel movements, either inability to control it and having that sense of urgency, or on the flip side, the other extreme is having too much of tightness where you're now having difficulty with emptying and unable to empty your bladder or unable to empty your bowel the way it's supposed to. So constipation or IBS type situation would also come under the realm of pelvic health. Anything with reproduction, anything related to the vaginal tract, this includes periods. So having pain with periods or having discomfort in and around periods is a good reason to see a pelvic physio. Pain with intercourse is a big one, because pain with intercourse flies under the radar all the time. And that is what is normalized most commonly, especially in the South Asian population. So I want to say no amount of pain is okay when it comes to intercourse. There should be zero pain, absolutely zero pain. If it's even 1%, it's grounds for a consult. It definitely asks for a consult so you can learn why is that 1% painful. So those would be the main reasons why someone should go see a pelvic physio.
So, I just want to maybe even clarify for people that are joining us today, like, why are we having this conversation? Why would we on our platform here think that talking about pelvic floor health is a good topic? I'm sure people are wondering that. So how would you answer that?
I think because of how common it is, because it's so common. When you start, I would encourage every one of your listeners to just have a conversation with their friend or somebody they trust and ask them, do they have any of these issues or on any of these topics that we've talked about? Have they even heard about these topics, or do they even know anybody who has ever experienced these symptoms? And the answer would be surprising. Because these symptoms are so common, it is absolutely important to talk about it. And what's more important is all of these symptoms are underreported. Therefore, they are underdiagnosed. And if we don't report it, if we are not diagnosing it, if we are not discussing it or seeking treatment, we remain underreporting this. Our resources, even though they are available, they are underutilized because not a lot of people seek that help when their quality of life could change, when they could lead normal lives without having to suffer through this. And also, because these symptoms, although they're common, we shouldn't justify them as being normal. There's a difference between common and normal.
Literally was going to say that. We normalize a symptom more than normalize the treatment.
Yes.
So I think literally I was going to say, thank you for saying that. Yeah, because everyone at some point, or most, and especially if people have had a birth, the pelvic floor, even just a symptom of like bladder control, release, all that is such a common thing.
Yes.
And it's easy to say, well, that's just that's truthfully what I thought for the longest time was, oh, that's what's supposed to happen. I've had 2 babies now and I've delivered them vaginally. So it more makes sense that I would have incontinence issues. And I think thankful that just as you gave advice, I had a friend this friend has never had kids, but because she works with the pre and postnatal care, she knew to bring that knowledge to me. And then it's like, what do you do for it? And so and the other thing I want to point out too is I think a lot of women know about pelvic floor health, and some are reluctant to go because of the worry of internal examinations. Right. Can we talk a little bit about that? Because I would hate for a woman to not go because she thinks that that's what's going to happen.
Absolutely. And this is such a huge limitation that comes in, which is relevant, which is very relevant. And as practitioners, myself, any of my colleagues, anybody who's trained in pelvic health understands this as a challenge. And that's why when we learn our coursework, when we're going through this, we are taught strategies of examining which do not involve internal examination. It doesn't necessarily need to be an internal exam. Internal exam is the gold standard because if I don't touch and feel and see the muscles, I don't know how well they're functioning. It's like going to a knee surgeon and saying, hey, I can't show you my knee, but I want you to fix it. I just can't show you my knee. But at the same time, in the same breath, I do respect and understand the cultural bearing of it. Not everybody would be comfortable in that situation, and that's totally fine. So when we go through that training, we understand there are some external methods to come to a diagnosis or to come to an understanding of what's happening. And a lot can be resolved just through conversation. This was a very important piece of all of my consults through COVID, because as I was consulting through COVID, it was through calls like these. It was video calls, and nobody was flashing their vaginas on camera for me. So it was just, consults like these. And because of these conversations, the questions that we ask and the detailing that we get into, we can have an external exam, or we can do a consult or a telehealth conversation and still come to a resolution. But the gold standard would still be an internal exam. And it's not something which needs to be done on day one. Once you get comfortable with your practitioner, once you've gained their trust, and if you feel safe and confident and comfortable, that's when you approach it. Because every single one of us is trauma informed. Every single one of us has gone through cultural sensitivity training, because people come from us in all stages of life, from all backgrounds, from all religions. It could be an immigrant coming in, it could be a refugee coming in, it could be somebody who's an assault survivor, somebody who's had an unpleasant traumatic experience. We have to take all of that into consideration and respect their understanding and boundaries, and still give them a solution. So my bottom line is, there's answers, there's solutions, and not all of them need an internal exam. Start the conversation. The first step is to at least have a conversation, and then see where it takes you.
Now, do most people, and I'm only speaking for Canada in particular, and I know we have listeners like that are outside of here, do we here need a referral from our doctor, or can we book, like, could somebody contact you or another clinic and book themselves in?
They can book themselves in. Luckily, in Canada, we don't need a referral to see a pelvic health physiotherapist. People could self-refer. They're welcome to choose a practitioner and just call their practice or call their clinic and book themselves in. And because it is a specialized branch of physiotherapy, if they have insurance benefits that cover physiotherapy, this gets billed under physiotherapy. So this is covered through their insurance benefits, and they can just self-refer.
So what happens if your body is sending signs and signals that you should go see a pelvic floor therapist, but you don't tune in, or you avoid, or you don't go? Like, what can happen eventually?
So these are the situations which we then see end up in a more dire setting, like probably getting into the ER, or being in a situation which might not resolve just by conservative exercise physiotherapy management. Physiotherapy is the gold standard when it comes to pelvic floor disorders. It has grade 1A evidence, which is the highest form of evidence in any treatment modality that we can find. But that intervention has a timeline. It has to be in a timely manner. If people ignore the symptoms, unfortunately, these symptoms are not of the nature that they get better over time, although that has been our impression. A lot of people believe that, let's just see what happens, and we'll see 6 months down the road or a year down the road if it's that bad. Unfortunately, no, these symptoms don't resolve if they're not intervened, and we might risk them getting worse. And the treatment for a much worse situation might not just be physiotherapy. It might involve lots of other things, like perhaps a surgery needed, or maybe something else down the road.
Is there a link to other health issues when the pelvic floor is not treated? Is there other risks that can occur outside of what you've already talked about today, in terms of, like, I know you talked about incontinence and all these other things. Is there other risk issues that could occur?
There's correlations for sure. There's definitely correlations that could occur. Not that the pelvic health would directly impact it. So there isn't a correlation saying that, if you don't treat your pelvic health symptoms, you're going to get heart disease, or you're going to get osteoporosis or something like that. But at the same time, it starts to affect other body functions. So if your pelvic floor isn't optimal, if your pelvic health isn't optimal, you're then looking at bladder dysfunction. Bladder dysfunction has ramifications ramifications in how your kidney functions. If your
Yeah.
kidney levels are not okay, or if your digestive system isn't okay, then we run into a whole host of systemic effects. Your electrolytes, your metabolism, your deeper inner body working, your systemic effects would have the ramifications of that. But it's hard to just pinpoint and say that A leads to B, B leads to C. It might not be a direct correlation to cause these things, but as a side effect, as a secondary effect, yes, one thing does lead to another because everything's connected.
I love that. Yeah, that's important. And maybe we can just talk a little bit about like I think a lot of this conversation today has been about breaking cycles and old taboos. Are there any other myths that you often bust when you have patients that come and see you where people are like, oh, I thought this was going to happen instead, or I didn't want to treat my pelvic floor because I heard this thing happens. Like, are there common things that we tend to make up and diagnose ourselves with or treat ourselves with and think that's okay?
Oh, for sure, for sure. There's tons, but I'll pick a few. Um, the most common one that I notice, or the first myth that I usually bust, is normalizing their symptom. When exactly like we talked earlier, whenever somebody comes in with bladder leakage, if it's been a few decades that they've been experiencing the bladder leakage, the common thing that they say is, oh, it was really good up until 2 weeks ago. And then I started to notice that the symptom started coming back. And I said, when did it start? Oh, it started 20 years ago when I first had my kids, but it's only 2 weeks old that the symptoms started to get back. So I kind of gently correct them and say, your symptoms didn't start 2 weeks ago. They started 20 years ago, but you've just lived with it. You've dealt with it because it wasn't severe enough. It wasn't affecting your day to day enough for you to draw attention. Now it's affecting it enough that you don't want to step outside the house without wearing a pad or a liner. And that's why you've come to me. So that's the number one myth, is normalizing something and saying it's not bad enough to go see a physio just yet. That's going to be the first one. The second part is about pain. When we talk about intercourse, this is my pet peeve, because anytime I ask questions in and around intercourse, the first answer that I get is to the question that I ask is, how much pain do you have during intercourse, or do you have any pain with intercourse? The answer often is, yeah, just the usual amount.
Oh,
And I
wow.
say,
Yeah.
what is the usual amount? According to me, the usual amount is none. There should be no pain. And oftentimes they go, no, just a little bit, the usual, that we have a tolerable amount of pain. And then I have to counsel them and say, no amount is tolerable. Pain is not in this conversation. We shouldn't have pain and intercourse in the same sentence.
That's
So
huge.
those are the two most common ones. And then if we take a cultural swing at things, the third myth is, oh, it's always been like that. My mom said that she had babies and she had these symptoms, or she had the symptom of a prolapse, and she's lived with it until she was 85, and then she got her prolapse surgery done. So it's not bad enough that I'm going to need surgery, so I'm just going to wait until I'm 85 and then get surgery.
Oh man, oh man. Oof. Can't
So,
imagine that surgery at that time in my life.
right? Absolutely. So these are very, very common conversations, and sometimes there's no fault in how
Yeah.
people present. It's just because they don't know, because it's been so normalized. It's just, yeah, it's obvious for them to believe this way because there is no other way that they would know.
Yeah, and I think it's conversations like these where we're trying to unnormalize the thing that we've decided is the okay, and we have to raise that bar for women's health,
Yeah.
and particularly the BIPOC women, because we do
Yes.
often in medical spaces in the Western world get left behind. We're not included in research.
Yes.
And so sometimes we're an anomaly. And I think sometimes that means that we have to learn how to advocate. So maybe you have some advice. Should we be in a medical space and we feel, how do we know and how do we advocate for ourselves and our health?
Yes, absolutely, absolutely. And I'm glad that you brought BIPOC women and BIPOC individuals in this conversation, because those stats that I quoted, those were not including BIPOC. Those are white Caucasian women stats. So when I was searching, and this is a constant thing, even to this day, right before our podcast, I ran a quick search to see, is there an update? Was there a new paper that was published that I'm not aware of that actually studies the South Asian population? And unfortunately, no, there hasn't been a paper yet that has effectively and comprehensively studied how is the impact in South Asians on their pelvic floor disorders. There hasn't been a study yet, at least that I know of. I'd be very happy if somebody comes back and says, yes, this is the study that came out.
Yeah.
I'd be
Yeah.
all over it to learn about it. But as of today, there haven't been studies because women are underreporting this, because people don't ask these questions. And it goes both ways, where doctors are also educated, and now there's a lot more awareness where they are supposed to be asking questions if our patients coming in don't volunteer that information.
Yeah.
And as individuals, the onus is on us. The advocacy rights, the right to make noise and to be heard until we find our answer, is an onus that we need to put on ourselves. We have to make the noise. We have to be the squeaky wheel that gets the answers, because otherwise these things won't get addressed. These questions won't get answered, and we need better answers.
Yeah. And I think sometimes even having someone with you in a medical space can help build that confidence in the moment to advocate, or if it's a language barrier, young
Right.
people going with their parents or family members. Because I think when you're in there by yourself, and I'm born and raised here, and I can say how many times I have been treated poorly in a medical space, and I know it's because of my color, and things have been assumed about me. I mean, even just when I was told this story before, when I went to give birth to my first son, everything happened. I didn't have a long birth story. I was one of those quick stories.
Yes.
And I remember right after, the medical team very openly shared how when they saw me, they did the whole thing where you put your finger to the nose and then not it, because they assume that I was like every South Asian woman that comes in.
Yeah.
And they think it's painful being the resources in the birthing space because of all these sorts of things that they talked about.
Yeah.
when we give birth.
Yeah.
And their way of telling me that was to compliment me and say, but not you, you did good, you were different. And so years later, you think about it and you're like, oh, this is interesting. And I think that was one of many times where many of us of color have been in an emergency room or in a doctor's office, and we're overlooked, we're questioned, we're told no.
Yes.
As you had mentioned early on in not accepting no, like we have to, that whole radical acceptance, our medical professionals sometimes have to help us. But one thing you said that really sat well with me, and I actually shared this with my sister on the phone the other day, and I really loved how you said this, because I was talking to you during the consult and I said, sometimes we just do the same old because of loyalty. And that might be that it's the proximity. So my doctor's office is so close to me, or I've been going to this doctor for many, many years, and it's a relationship. Maybe it's not the best and I don't want to leave this doctor. And so that gets in the way for sometimes some of us in advocating for ourselves,
Right.
or going to get another opinion. And I love how you said to not look at it always as a negative thing, but even going to our doctor and saying, like, you've taken me this far, you've been able to help me with these things, and I don't want to also take up more space, so that you can also tend to other patients, because I feel this issue is going to require more time. And so please help me with the referral, or I'm going to deal with this part of my health issue with this specialist or a women's health doctor, or all those things. And it was such a, just so you know, it was so well said, and it really stuck with me, because I was like, oh, that's such a kind way to say it, because I don't want to get in a fight with my doctor. And I think a lot of people don't want to.
Right.
And you said like a lot of times these family doctors only are given so much time too. So we get mad at them as well. But they only get to do one or two things per visit. They can only be as thorough as possible. Yeah. And we can also be responsible on our end too, and say, actually, I'm going to go to this women's health clinic or this naturopath or whoever to help me with this thing. And I think that was a really good message that a lot of us need for validation, because we just put up with it sometimes and think, well, my doctor would tell me at least, or it's not that bad, or whatever else happens in between.
Certainly, certainly. No, I thank you for reminding this, because I think that's a conversation I have on the daily with so many individuals, because whenever they come, there's a handful of them that come to me as a referral, and there's others who just make an appointment and they would walk in. So every time they come in as a referral, one of the things that comes up in the conversation is that, oh, my family doctor is great. I'm not saying that they're not doing their job. I love my family doctor. They're really great. And I resonate. I validate that and say, of course they're great, because they've taken the effort, they've taken the onus to actually delegate this part of your health to somebody who specializes in this field.
Yes.
They're not trying to wing it. They're not trying to band-aid fix it and say, oh, let me just do this right now so it can help you for maybe another month or a couple of months, and then let's come back in a month and see what you have to say. So I really like the fact that when we have these conversations with patients, I tell them about the closet metaphor that I talked about. So I teach them this understanding that treat your health as if you're building your closet, right? We don't really stick to one type of an outfit all throughout the year. We change our outfits based on season. We change our outfit based on the time of life we're in. What we wear as a young adult is not what we wear when we're older, and then winter versus summer. So there's all different sizes, types of outfits from all different stores. Although we might have a favorite store, we might have a default clothing store that we really are comfortable with and really enjoy wearing clothes from, but that doesn't make all of the other stores any less important. Based on the occasion, we pick out our clothes. So if it's a fancier occasion, we've got the fancier outfit. If it's a workout occasion, then you've got your workout clothes. If you're just a casual evening, then you've got your casual clothes. Exactly like that. Treat your health team based on their expertise. You have your family physician for everyday aches and pains, the general, the flu and the cold and cough and things that needs a central program manager planning hub. So all of your reports come to your family doctor. They manage your entire lifespan of health. But when it comes to something that needs a little bit more nuanced, a little bit more specialty, then if it's a knee surgery, they would refer you to a knee surgeon. They wouldn't do the knee surgery themselves, although they might know exactly how to do the knee surgery, but that's not their expertise. That's not who they're going to send you to. So very similar to that, if there is a gynecologist, if there is a pelvic health specialist that they want to send you to, those are valuable referrals, and that doesn't make them any less important, or that doesn't make you a traitor for seeking a second or third opinion, because these are just people in your health team. These are tools in your toolbox or outfits in your closet that you're curating together.
Yeah, that's very well said when it's put that way. It's definitely helpful. I remember you saying it's like the seasons of your health. And it's like, that's so true. What you need as an annual physical checkup is going to be different than maybe this one little thing over here, which is your pelvic floor that needs a little extra special care. So Rama, we talked about silence. We talked about myths. We talked about the in-betweens. We talked about, starting young and teaching our children early so they build confidence as they get older and they feel comfortable advocating in a doctor's office or know, oh, this is my pelvic floor that needs tending to. Is there anything that from the consult that you wish I had brought up today or asked, or you want to go back and add to?
No, I think you covered a whole lot. This is much more than what I would have imagined. So thank you for touching base on all of those topics. Those are intricately woven together. So I'm glad that you brought all of these all in one frame that we can have open, honest conversations about.
Yeah, and I appreciate you too, because you have like wealth of knowledge. You have a lot of empathy in your answers too, because I think you've been there, you get it, you're a woman, and you've seen all sorts of things, I would imagine, with your patients. And at the end of the day, it's like everyone is not the exact same. While we have similar issues, we also have genetics. We have all these different ways that we've lived our life. And, somebody had said, two people buy the same car at the same time, you're going to have different issues,
Yes.
mechanical issues with your car. And I think we have to remember that about ourselves as well.
Yeah.
So why don't we get your MFU? What is something that you would put your middle fingers up to if I had asked you?
I'd love to put my middle finger up to silence and stigma. That is the one thing
Mm.
that I am passionately against is, yeah, don't stay silent. This is not something which one should be embarrassed about. It is not a bearing on your character. It's not a bearing on who you are as an individual. Symptoms are symptoms, issues are issues, and these have no bearing on your identity. So silence and stigma have no place in the room. Put your middle finger up to them.
Oh, well said. I love that. And if there was one thing, only one thing, let's say are those that are with us in this conversation today left with, what do you really hope that one thing is?
The one thing that I want people to leave with is to not accept what is not okay. Just don't accept what's not okay, because the start of anything in life, it could be a health concern, it could be an emotional health concern, a physical health concern. Whenever it comes to health in general, if you know it's not okay, then just don't accept it. Because oftentimes, before it becomes a symptom that's nagging, we know in our bones, we know in our heart that, hey, something's not okay. And it's just us trying to talk ourselves out of it, where we try and rationalize this and say, oh, it's not that bad, or I'll wait and see what happens. It's that window of acceptance which drags on longer than it should. So the one thing that I want people to leave with is to not accept what is not okay.
I love that. Very well said. I'm so grateful that I met you a few months ago. I'm so grateful that when I reached out, you said, yes, I want to do this. I'm so grateful that it happened today. And I think what you shared is very, very important. And I would imagine people might have some follow-up questions. Maybe they want to book with you. Maybe they want to follow you. Like, where is the best place to reach you?
The best place to reach me would be at my clinic. I practice at Lakeview Physiotherapy, which is in Southwest Calgary. That is my primary clinic where I practice out of. So that's a very good place to just pick up the phone, call, or just type in Lakeview Physiotherapy on Google and it'll come up. I also have a website. It's called healwithgrit.com. So if people want to learn more about what is pelvic health physiotherapy and how does it help and a little bit about me, they can go check out that website. And these are the two primary places where they can reach me.
I love that. And I'll add that in the show notes too for people so they have access to that as well. So again, thank you. Thank you for the work you do as well. Thank you for attacking the conversations that we really, really need to address and, unnormalizing the thing we've normalized and
Yes.
normalizing the thing that we have not normalized. I really appreciate that you're helping some of us rescript that and make those changes. And I think it's going to, more than anything, support this next generation that's growing up in the health system and understanding their bodies and their self-worth at the end of the day of like, I don't need to suffer. I don't need to go through these things. And thank you for addressing the stigmas that you're a pelvic floor physiotherapist and all the branches that came out that were beyond that. So you're probably, I would imagine I had gotten testimonials, I would imagine a lot of your patients would probably feel like they had a great therapy session outside of bladder support and everything else that they came in for. So I appreciate that. Appreciate practitioners like you that care for your patients.
Thank you, Kiran. No, I couldn't be more grateful for the opportunity, for the platform, because these are honest, needed conversations that all of us shy around. So the more we talk about it, the more stigma there is that's broken. It makes it easier. So even if I could influence one person to step out of their comfort zone and to reach out, I think we've accomplished something huge. We've made a difference in their lives. And I just feel grateful that I have the opportunity to do that work every day. That's what gets me out of bed every morning, is just the sheer joy of influencing another person's life, and having a teensy part in making their life a little bit better so they can live with more confidence. That's honestly the joy of my life.
I love that. And lastly, I would encourage, because I would imagine we have a lot of women tuning in today. Like, this is a really good topic for our male partners, all the men in the world, because all the men in the world, you are connected to a woman in some shape or form. And there's a lot of revamping the dialogue that you guys have been taught about women and women's health. And we kind of need to do this together. So I really hope this episode will be passed on to men, so you guys can tune in and go to the appointments with your partners, whether it's pelvic floor or whatever hormonal health appointment it is. It's just as important as prenatal appointments. So if not more in some ways. So
Yes.
I just really hope that happens, because we got to do some work in that department. And maybe that's another conversation you and I can have at another point.
For sure, for sure. Yeah, that opens up a whole different door of things to talk about, for sure. Yeah.
Right? That's what we do right before we leave. And as you said, these conversations, thank you for reminding me. I always say they're door openers.
Yeah.
We're just starting to have them. We don't know all the things. So we need people's feedback. We need, your thoughts. We need to know what activated you in this conversation, because we're collecting data as a community, and these conversations are part of that. So we need everyone's voice in, hey, this was helpful. This wasn't. I want to know more. I want to contribute.
Yeah.
You know where to find Rama now. You know where to always find me. We're listening. So thank you very much.
Thank you.